Okay, good to go.
Thanks, Katie. Hey, good morning, everyone. It is 10 o'clock. So we will get started. Welcome to the final, likely, meeting of the Values and Principles Work Group. Today, we will be going over, Katie, can you go to the first slide, the agenda slide? We will be, as usual, doing a little bit of a welcome, a review of the agenda, and then Katie will call the roll before we get into the discussion. Today, we're going to be talking about the recommendations and considerations that we've been covering for the past 2 meetings, and then coming together for a final conversation to make recommendations that Katie and I will then put together with Warren's assistance to go to the board for the meeting on June 20th. That's a week from tomorrow. The materials for the meetings, we try to get out a week in advance. So whatever we come out of today, Katie and I are trying to do a fairly quick turnaround. Sorry about my dog. We'll try to do a fairly quick turnaround and get that posted so that everybody will be able to see it before the final meeting, or I'm sorry, before the board meeting. So as usual, public comment is not going to be taken during the meeting today, but you can always submit public comment, either a written comment to the email address that is on our website, or you can come to the meeting on June 20th, and we do take public comment in person at the meetings, either virtually or you can come to the meeting in person. This meeting is being recorded, I believe. And so the goal for today is for all of us to come to an agreement and figure out what will be moving forward as recommendations to the full board. As I said, this is likely the last meeting. This is the last scheduled meeting. There is the opportunity, there's nothing stopping us from having further meetings, but I think that this will probably be the last meeting as we put the recommendations together for the board meeting next Thursday. So as I said, for the agenda, we'll review the recommendations and the feedback document that we sent out last week and have a conversation, and then try to narrow those down to the recommendations for the board. So Katie, if you will call the roll.
Yes. Amy Fellows.
Here. Excuse me, here.
Michelle Glass.
Present.
Debbie Diaz.
Present.
Chinwei Chi.
Present.
And Warren George.
Here.
Wonderful. Thank you.
Okay, and I will hand it over to Warren to kick us off. Katie, you can go. Thank you.
Okay, so where we left off last meeting was that Jenny and I would work to distribute a rough draft, hoping to get consensus of what we could present to the board, and asking for your feedback. We got feedback from 2 people, have not really had a chance to incorporate that into the document yet, but we have some ideas of where we need to place some concentration. It sounds like everybody was largely in agreement with several things. One was to move the value recommendation from the Health Equity Commission to the top of our document as a general principle, or as a general recommendation for the board to accept. But there was also concern about whether this statement adequately defined equity. So I'll open the floor to particularly to anyone who might want to talk about the definition and what we can do. And for myself, I would recommend that we put it in this same section up at the top of the document. So does anybody have a definition in mind, or other discussion on this particular section of the proposed recommendations?
I'm not clear, a definition on which?
Jenny, can you help me? This pertains to a specific question that we put out to members as to definition of equity.
Sure.
Yes, we asked, do you need better, do we need to better define equity? And we received 2 comments that we should better define equity, and including in those comments were that that while the ATC recommendation is kind of aspirational, it's not really a definition. The fact that there was interest in better defining equity, I'm open to suggestion of what that definition might be. And one of the comments was just to try to get help getting the discussion started. One of the comments was kind of the difference between impartiality and equity. Debbie.
I'll just chime in since I was one of the comments and just try and kind of simplify my feedback. But I guess I was just kind of struggling with finding a balance between an oversimplification of the definition versus something which might be overly complex. And when I think of definitions and where they're helpful, it's about providing clarity and something clearly understandable. And I got a little bit lost. I agree with the sentiments here, absolutely. And I just kind of got a little bit lost in thinking about like the clarity of it and how we actually make it truly actionable. And so, yeah, that was kind of my long-winded feedback. So thank you.
Well, it resonated with me, which is so Michelle.
I think I was the other person that commented. And I think that when I read this definition, I think we are defining something complex, I guess is my perspective. And so I don't know a simpler way to define this because this is my understanding of the definition of health equity or equity in the sphere of health. So I guess it is complex and it has to account for that, I guess is my thought. But I think where I was coming from is responding to some of Dr. Chi's, I believe, comments around, I think that how we apply it, especially when it comes to fair distribution, is where we need more refinement. And I am not clear on whether that's part of our scope in this subcommittee or if that is part of the discussion with the full board. And I think it could relate to the citizen jury. It could relate to some of the other aspects that we're looking at. But to me, I guess that was what I was pointing to with my comment.
Thank you, Amy.
Yeah, I mean, I agree with Michelle that I actually, in the health equity realm, really have always appreciated since this definition that we're looking at came out. And in conversations that happen across, like public education and across industries, what I like about this definition is it's actually talking about equity. And what I see happen is equity gets watered down to equality. And they aren't the same. Equity is making sure that we are reaching, crossing things to make sure there aren't disparities. It doesn't mean you treat everyone equally. Equity is something very different. And that's why I have always liked this particular definition, because a lot of our institutions and systems seem to confuse equity and equality that are two very different things. But if we're talking about health equity, I like this as our overarching, and because it's already something that's consistent in other parts of the state.
So to be clear, you could be satisfied with this statement as a matter of respecting equity.
Absolutely.
Chunwei.
Yes, I also agree with Michelle's comment about the HEC's statement is more like a mission statement. The challenge for us, the board, is we have to operationalize it in terms of how do we prioritize healthcare to whom. And more broadly speaking, there are, in terms of the universal health system, there are at least 3 different dimensions of equity, and they may need to be clarified and be very explicit, meaning operationalized, because that's how we have to design the system. And for example, financing, taxation, that's one important dimension of equity. And most countries with public universal health care system, their financing in terms of taxation equity, following there seems to be wide consensus across countries. The general principle of equity is based on ability to pay. That means people who make more income on average contribute more than people who make less income. So that's the ability to pay principle applied to financing part of the equity. And then the other side of the financing also needs a separate operationalized principle of equity. That is, how do we pay providers? How do we pay physicians, nurses, and hospitals, clinics, etc.? So that's another dimension of equity. And then the third one, equally complex with the first one, the financing part of the taxation. The third one is equity in allocation or distribution of health services. And in my earlier presentation, I mentioned about some popular principle of equity in healthcare. So for example, equal access for equal need, or equal access for equal ability to benefit. But judging from our discussion, I suspected the board member might be in favor of the broader equity in health. The equity in health has a direct implication on how we design the prioritization of healthcare. Because if our goal is equity in health, that means we need to prioritize healthcare to Oregonians whose overall health status are below the average. So they should get first priority for their services. So each principle has a direct, profound impact on how we design the health benefit, to whom, and how we allocate that. And the whole issue is so complex. I don't think our work group can finalize it, but I'm proposing and suggesting, instead of trying to finalize a principle, how about we think about the process? And we don't need to finalize it within a month or so, because again, if we want to respect the community ownership, we should bring it to the community and to find the prevailing value preferences from the community. So probably one of the important tasks is, given the challenge and complexity, how do we move forward and bring that issue to the full board?
Okay, thank you, Chunwei. Jennifer.
Dr. Chi actually said several of the things that I was thinking, and I wanted to present it to the group like this, in that I think that, first of all, the way that it's sort of laid out, this definition from the HEC is laid out, it gets a little bit muddled because of the establishing sort of paragraph at the beginning. But I think going back to some of what Amy was saying too, in terms of the difference between equity and equality, the finer points of this definition, if you leave out sort of the action statement of it, is the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices, which I think gives sort of a more succinct idea of a definition if you kind of take out some of the noise around it. And going to Dr. Chi's point, establishing this as a value means bringing it into the conversation around financing, around operations, around plan design. So taking this sort of definition that you would present to the full board to say, this is how we're looking at how equity comes into play, to say, as you look at financing, how are you ensuring that we're first communicating with all regions of the state, including tribal governments? How are you ensuring that we're looking at equitable distribution or redistribution of resources? And how are we recognizing, reconciling, and rectifying historical and contemporary injustices, and carrying that value through each examination for each work group or committee that the board puts together to start looking at and examining these issues? Does that make sense to everyone in terms of how like we would apply the definition and how we might carry forward the recommendation?
For me, I think the discussion from a practical sense is that we really do want to operationalize this and not just have it as a mission statement, but we're probably for the moment satisfied to prepare for the board discussion and with the language that we have here. And it can lead to opening up a little bit more discussion with the board. And actually I think the opening statement is very good, but certainly the things that we will be working with is the equitable distribution or redistribution of resources and power, recognizing, reconciling, rectifying historic and contemporary injustices. So do we have a consent? Oh, Michelle.
I know you're moving towards consensus, and I don't want to slow the process down. I just two quick thoughts on this discussion, which I think has been really helpful. One is that I do agree that this is not something, this isn't the implementation, but I think without clarity on what our goal is, that guides implementation. So to me, like, both are important, and this is a prerequisite to being able to decide how we operationalize equity. And so I find it helpful in that way. And then the second thing that I was going to just mention is reiterating that, again, my goal is equality. It is fairness, but we can't get there without equity as a strategy. So I just want to make sure from a communications and a community engagement standpoint that we lead with, yes, that is the goal, equality, fairness for all people. And that's why we're holding up health equity as a strategy. So again, not allowing those to sound like opposing ideas. They're not the same thing, but one is a means to the other. So just reiterating that for the record.
With the goal of being ready for the board meeting, do we have consensus that this is our opening statement is satisfactory to start the board discussion? Hey, looks to me like we have consensus. So Katie, if you could move to the next slide. So we had a somewhat longer explanation for each of these, but we concentrated on these 4 areas, and we've changed the names a little bit. We went from, I think, prevention of poverty to minimizing financial hardship on individual patients. And I think there was some interesting discussion around this, and it's about how, how far do you go and how do you define it? I think when we started with a definition of minimizing poverty, there was concern about we only control certain aspects of poverty, and we need to be more concentrated on poverty as a result of, or it's one of the things that led to the change in wording, or the proposed change in wording. So does anybody want to talk about the wording of any of these 4 overarching principles, and whether we have consensus that these are the wordings and the 4 principles that we want to take to the board? Debbie?
Yeah, I would just, my feedback was not thinking of it in terms of either or. I wondered if we could minimize financial hardship as well as protect against poverty. So just kind of, and then I think this will come into more when we operationalize things, but ultimately, what does it mean to minimize financial hardship?
Thank you. John Wei.
Yes, I concur with Warren's comment. To minimize or prevent from poverty goes beyond the capability of the universal health care. And therefore, the language on the 3rd one might need more clarification, because the financial hardship on individual patient could be resulted not just from healthcare, but from other aspects such as losing job, etc. But I don't think the universal health care in terms of financing has that capability to compensate lost wages. In UK and some countries they do compensate lost wages under their national health care. But I don't think we, well, and I'm open to that unless we want to go that far, including compensating for lost wages. If we are not going that far, then we need to limit the financial hardship due to healthcare or related to healthcare. So on individual patient, that is still a bit broad. And again, it depending on how far we want to go in terms of protection against poverty or hardship beyond healthcare.
Michelle?
Thank you, Dr. Chi. That makes sense to me. And my feedback, which is captured in the document that was sent out, is really just focused on trying to conceptualize what that would mean. And where I went with that was some wording around what can we control around cost sharing? What are some reasonable guardrails around cost sharing? Is there a principle there that we could implement that would help to focus this minimize financial hardship from healthcare costs more directly? And wondering if that was a way that we could focus that.
Thank you, Michelle. Amy?
Yeah, this may be too much in the weeds, but something that comes to mind is in addition to, things like people going bankrupt because of, medical bills and things like that. I have a friend that actually was arrested because she didn't show up to court for collections from medical debt. So then that furthers, poverty and access to work and other things. So I don't know, that entire kind of system that we have currently in place, where things like that are possible. I don't know if that gets wrapped up into any of this.
Speaking for myself, you know, I've wondered if the word bankruptcy somehow fits in this as kind of an understanding of the sort of thing that we're trying to minimize. You know, but we can't avoid all bankruptcies. You know, we're I think targeting the financial hardship that's caused by the medical financial system, since that is the area that we're mostly concerned with is medical financing. Could we change a word or two, like minimize individual hardship due to medical financing, due to the medical financing system? Does that get us any closer? Too long?
Or due to medical debt?
Or medical cost.
Well, I like what you said, Michelle, but to me, that's still kind of struggling with medical cost. You know, could be my uncle in New York, you know, requires me to fly back and forth or something, and I don't think we can reduce the cost of airfare. So I'm worried about getting too general. Debbie.
Yeah, just to kind of piggyback off what Michelle says, I do like the idea of including costs, just because I think once we get to debt, we've already gotten to a step we're trying to avoid. And I do recognize what you're saying as far as like what we can control, because I was having similar thoughts on like, well, what about dependents and parents of dependents or family members and kind of all of the costs that go associated with caretakers that we may not have control over. But I do think using debt and bankruptcy and terms like that without including something that is not to that extreme kind of gets us back into the same position of just avoiding poverty and not thinking about all the steps leading up to that.
Michelle.
This makes me wonder if we are just going to need to define terms. I mean, if we had definitions for all of these, which I think would be probably important, I think we could. I don't know if we can wordsmith our way. If we wordsmith our way to a perfect definition, I don't know how plain language or understandable it would be to the average Oregonian. So I wonder if definitions would be a way to be clear about what we mean while also being able to say something that is not too long and convoluted.
Just to understand that, so something like minimize financial hardship might be okay if we defined, or minimize individual financial hardship might be satisfactory as long as we had an understanding of what that meant. Potentially,
like in a legislative bill, starts with definitions. So if we use a particular term like financial hardship, or due to financial hardship due to medical expense or something like that, then each of the medical expense would be defined, financial hardship would be defined, and that way we would be clear without having to have a full sentence as a principle. So a phrase like minimize individual financial hardship from medical expenses might be a better phrasing. I'm seeing people nodding. Chunwei.
I agree with Michelle. We want to find a simpler term. At the same time, it's also clearly define the boundary and easy to understand. So these are the challenge we are facing. And I suggest we might need the language a little bit broader than medical bill, because one important implication of this third principle actually related to financing, the taxation. And so a broader term would be health care. Healthcare would include both medical bill as well as the taxation. The healthcare finance include taxation. So it's more than just medical bill. So for example, when we design taxations, we need to accommodate people who are very low income. We don't want the taxation to add their financial hardship. So that's another dimension of financial hardship. We also need to be inclusive in this principle. So I suggest something a little bit broader than medical bill, like health care.
And somebody helped me figure out how to put that. I was leaning toward minimize individual hardship due to medical bills. But did you just say that that's not broad enough for you? Yes, John Wayne.
One possible and also relatively simple language would be minimizing individual healthcare financial hardship.
Jenny?
Sorry, I've been trying to write up what about minimize the impact of the cost of medical care on patients? Patients might be too narrow. Because I was looking at the feedback document also, and one of the other feedback pieces was had incorporated the idea of access into this principle in terms of individuals not seeking care due to cost prohibitions, making cost prohibitively high. And I'm wondering if we're looking to minimize the cost on patients as a principle. And I don't know if that gets at the entirety of the statement that is trying to be made. Dr. Chi, please go ahead.
Yes, I just want to supplement that what I mentioned earlier, that the financial hardship, yes, largely maybe come from medical bill, but don't forget there's also a financing part, the taxation. And so we want this principle to also address the financing part. So for example, people lost job or people have very low income, we don't want the taxation to add financial hardship to them. So that's another dimension we also need to include within this principle.
Yeah, for me, I think the removing impediments to care is due to things like copays and point of service payment really belongs under maximizing health. And what we're talking about in the distribution, well, what we're talking about in avoiding the financial hardship is really the effect on any individual, not necessarily effect on the individual finances, and not necessarily effect on health per se. I think that goes in the health box. Well, what I would suggest, if we could just go back one slide, Katie. As far as the titles go, Jenny and I will confer and put something in the slides for the board based on this discussion. And unless anybody has any objection, if it's wrong, we can discuss this more in the board meeting. So is there any objection to that? I see no objection. So let's move on to some of the sub discussion. Maximizing health. And Katie, if you could actually display the full document, the full draft document. That's a bit small on my screen. Yep, there you. Okay, so if you can scroll down to the section on maximizing health. And we didn't get any feedback against A or C, but I think we have enough feedback in from our discussions. We've got, I don't think we have, I think we have some more things to discuss as far as population measures. And I have attempted to draft a statement which would say population measures are difficult while establishing measurable health care goals is a specific requirement of SB 1089. The general measures of life expectancy, quality, and others can be subjectively discriminatory against specific populations or use averages to disguise disparate effects and the use of such. Well, let me stop. I mean, is that a general statement that would be a reasonable statement to the board and kind of explain? Yes, Senate Bill 1089 requires us to actually come up with it. The actual wording is of 1089. Establishing measurable health care goals and guidelines that align with other state and federal health standards. I hadn't realized how difficult that part was going to be, but could we just support a statement that general measures of life expectancy, quality, others may be subjectively discriminatory against specific population, use averages to disguise disparate effects? Amy.
I was, and again, this is getting into like the whole definition thing, but on A, is there a general way that other organ benefit programs or whatever define resident, like how long someone has to live in Oregon to be considered a resident?
The task force dealt with that a little bit, and generally there was a couple of definitions. One was to consider what Oregon Health Plan defines as a resident. Another would be voting, but I think since not everyone is that could be used to clarify, not to define. Do you have a specific population concern, Amy?
No, I just was wondering, you know, that seems like something that we would, to operationalize, would have to define what we mean by resident, and it would make sense to look at existing definitions for state programs.
Yes, thank you. And by the way, Amy, as facilitator, I will carry the what we come to consensus with. I will carry that to the board. But I would like you to be prepared in the board meeting to talk a little bit about the legality of things like quality and some recent developments, if you'd be willing to do that.
Sure.
Okay, Chunwei.
I have a kind of a suggestion in terms of strengthening the language on the B population measures. My suggestion is we add a short sentence indicating the board will be working with the community, the Oregonian, or we can use Oregonian community to identify an appropriate and acceptable population health measurement.
So the board will work. Is this relevant to the measures question? Then we'll have the community weigh on what measures they think are important. Can we go there?
Yes, because eventually we need to identify certain measures that reflect how well the universal health plan, the system is working in terms of maximizing population health. And so we don't need to identify those measures, but eventually we will need to. So it's the importance of the process. The process, how and who choose, who decide, that matters.
And it might be good to clarify like that we will specifically those most impacted, you know, like disability community, BIPOC community. Those are typically who are most impacted by potential discriminatory measurement practices. I don't know if we're keeping this sentence, but on B, where it says subjective basis, is that supposed to be bias to avoid subjective bias, or is it supposed to be basis?
I suspect that it's meant to be bias. I like Chunwei's comment about community measures, and I do appreciate the identifying specific communities. And those communities, Amy, Jenny, have you got the ones that Amy specifically spelled out? Okay, thank you. Chunwei.
Yes, I just want to clarify a common misunderstanding or misperception about the term or concept of subjective. Each individual health measurement can be subjective, but many of them are objective. For example, fatality, preference, these are objective measurement. Life expectancy, they are objective measurement. But in terms of choosing which health measurement to represent our health outcome, that choice is subjective. No matter which indicator we choose to represent health is subjective. So we want to be careful of avoiding that term subjective, because ultimately our choices are subjective.
Okay, thank you, Chunwei. Michelle.
Just responding to the suggestion to include specific populations, my friendly amendment to that suggestion would be that it's based on data for health disparities at the time, which could change over time. So it's not static groups that we pick, but it's the groups that are experiencing the biggest health disparities at a given time.
So that would the word like contemporary, or do you have a better word?
Well, I don't know that this is going to go in this language, but you had asked Jenny to mark down those groups. And so I was just adding that suggestion to
Okay.
amend.
Thank you.
And I was speaking not necessarily, I mean, although they are the same groups, about health disparities, but about the groups that are most impacted by traditional life expectancy or population health measures. But they are usually the same groups that have health disparities normally.
Okay. Something that nobody has mentioned, but and it was kind of around the fringes of the conversation when we give individuals certain control over their healthcare. There are certain situations in our society where we don't do that, and I've tried to walk a line with that in suggesting some of the wording that is in C that actually it kind of says, yes, it's the individual who we want to be able to decide about their own health, except when community contagion is involved. Does anyone have any feedback on the trade-off between those two? I don't think we can perfectly define it. Well, seeing no objection, we will make some changes specifically under paragraph B, and we will do the best we can. And when we show up in the board meeting, we'll have another opportunity to discuss those. So if we could move on to the fair distribution, and we can either go with the specific slides. Chunwei had some other words that are synonymous with these. These just kind of came out of the discussion, and does anyone have any? I mean, this is where we're really looking for to the community itself, and this is a place where we may recommend citizen juries. In fact, so does anyone have any specific concern about wording of this in the recommendation that we pass on for board discussion? Michelle.
Apologize for being off camera. I'm having some bandwidth issues. So audio is cutting out for me. My take is that we still haven't answered fair to whom, which is a question that Dr. Chi keeps, I think, pushing us to wrestle with. And I did appreciate the article that you sent, Debbie. Thank you for this article on alternatives to Quali and Dolly. I was intrigued by multi-criteria decision analysis as a potential to explore. And it seems like one of the inputs to that could be, input from Oregonians alongside cost, clinical outcomes, and some of the other measures. So I liked the flexibility of that to incorporate and weight different inputs. I'm not sure how feasible it is because seems like a more complex measure, but I thought it accounted for some of the limitations we've discussed of some of the more objective and simpler measures. The other comment that I had on fair distribution was that this is a place where I believe that our overarching commitment to health equity applies. And this is a place where one way that we can make sure that we are engaging in fair distribution practices is by recognizing and responding to systemic and structural barriers to accessing healthcare and into achieving good health. So I thought that that might fit as a sub bullet point here.
Yeah, I could agree with that. Have you got that? Have you got that down, Jenny?
Yes, that was in her recommendations.
Okay. Does everybody support that addition? I see general smiles, so I'll assume so. Chenwei.
One issue related to this fair distribution, we may want to bring it to the full board. In terms of one particular issue, we haven't fully considered is fair by region. And both Warren and Amy were present in last Saturday's HCAO annual meeting. The last session, one of the discussion talked about the corporatization of clinic hospitals. And that will have a profound impact on all Oregonians to the extent when the for-profit corporation take over some hospital clinic, some of their action is to shut it down. And so we will be potentially facing this issue that, yes, Oregonians have universal health plan, but they don't have access to health care depending on where they live. So that is an issue related to this fair distribution. And it's beyond our work group's capacity, but we need to bring that to the attention of the full board, that in the designing and planning of this plan, we have to take that into account, into serious consideration, so we don't face that some Oregonians have universal health care but don't have access to health care in their region.
Thank you, Chenwei. Amy.
Yeah, I just want to second that, especially living here where Oregon Medical Group was taken over by Optum, and there's 3,000 people in my community that don't have primary care providers and can't find one. So very valid point.
Debbie?
Yeah, just piggyback off of that with just provider or clinician rather shortages, especially disproportionately affecting rural communities or access to tertiary care. I know at OHSU, patients will travel hours to see their specialist because they don't have access in their community. So I think this is really important and definitely something to consider as we think about workforce readiness and incentivizing clinicians to come to Oregon, stay in Oregon, pursue primary care, and be distributed in areas that are rural as well. So I agree, very important.
And I guess in some ways, we haven't discussed it yet, but we're adding a section on community governance. And it would seem to me like maybe that's where the workforce issues kind of belong under the community discussion. Yes, no, puzzled looks. Amy.
Well, and I think under the community discussion, but then also I wonder how our body will interact with other state bodies that are wrestling through workforce issues. There's a mental health work group that's active right now, or workforce work group. I I don't know. I think there's a health related one as well. So we don't necessarily have to recreate processes in the wheel, but it seems like we need to engage and understand other efforts around workforce that are already at play, and then also involving the community.
And these are issues which we would hope to come up in this community group establishment of values, and certainly one of the things that I believe personally is that we should be thinking about healthcare a little bit more like we think about fire departments. If we have a standard that we have a fire station within 7 minutes of all places in a certain area, should we be thinking that we have care within a certain distance of, and I think that's kind of covered in some of the regional questions that will be different for different areas. Do we have anything more to add to the discussion of under fair distribution? We'll move on then to minimizing financial, whatever this title will be, minimizing financial hardship on individual patients. And I guess there's really kind of two ways to do that. I mean, we're trying to spread out. My understanding of this particular goal is that when we have individuals who are outliers and incur a lot of cost, that we're trying to make it so they're no longer outliers, and that cost is spread out more widely. So I think that's an important aspect of minimizing. Also, and part of that, I mean, the way that would be operationalized is reduction of cost sharing, reduction or elimination of cost sharing is one thing that spreads out the cost more widely. And something that I don't know if really belongs there or not, but it's kind of an aspect of maximizing health. When we think of things that are extremely expensive to individuals and to society, we should be looking for ways to cure, prevent, or figure out more efficient ways to deal with particularly high cost ideas. So that's what's up there now. Does anyone suggest any changes or additions? Chunwei.
Yes, I suggest we need one addition to the dimension I mentioned about taxation, and some language like the financing based on ability to pay. That's as a general agreeable principle.
I'm okay with that. Debbie?
Yeah, I just wanted to, I think these are important, but also thinking about encompassing things outside of significant illness and injury. And I know that kind of gets into other areas. So, but yeah, I do also appreciate the, high cost events. I think that might be easier to define from like the kind of less in the individual way. I feel like individual high cost, that's more subjective. What's high cost to one person is very different than what somebody else perceives at high cost. So I just caution using that value judgment without knowing individuals' threshold for that. But yeah, I guess if we could just figure out a way to include some access, and I think Dr. Chi's comment maybe talked about that, got into that a little bit with ability to pay, but just kind of thinking about that, not just in terms of significant illness, injury, and high cost events.
I like that. Chun-Wei.
Yes, I just want to add one kind of important issue that will be for the whole board to carefully consider is potentially the taxation will face a huge barrier both from the community and from the legislatures. And that's why it's even more important to address the equity issue in taxation in this sections, minimizing financial hardship, to address that. So we can remove any concern, any doubt that our tax will add additional burden, particularly for people with low income. And so that point is very important to communicate with the legislature and with the community.
Anybody else on this section? Okay, there was in comments a desire to maybe describe a little bit more about community ownership. And I agree with that. I've kind of prepared some of my own thoughts, but I'm curious what other people have on their mind in that section. Chun-Wei.
Yeah, I apologize. I should have sent everyone the article I mentioned, but my past week and this week have been crazy. That this is the end of the term. We have so many defense and final oral exam, and I will have to work in the evenings. So after today's meeting, I will send everyone that article. And so the concept of community ownership was first coined in the article published in 2018. The idea was developed in 2010. And in a simple term, as a general principle, community ownership means for any policy program that will be direct and intimately affect to the community, like that community should have the final voice, final decision-making power. So that's the general principle, and we can operationalize that, how we operationalize that concept or principle into key decision making. And of course, the idea of community ownership, meaning community will have the final voice, final say on the key decision making, but not to the minute detail. That will be not feasible in a large community like the whole state.
Yeah, I like that. I like that definition. I think for me, this community ownership actually contains some other things. I mean, a healthy community, I think, has ability to make certain decisions or to realize certain. I mean, this is where some of the interconnectability with other things, like one of the things that that speaks to me under community is our long history of associating healthcare, access to healthcare with employment. I think is harmful to the community in several ways, including that there's lots of evidence that it has made a significant impact on a loss of jobs, particularly for the lower middle class. And so I see that being kind of connected with the community, that meaningful community life, including economic life of the community. Chun-Wei.
Yeah, I just want to supplement some of the explanation, which I talked a little bit in my speech on last Saturday's SCO meetings. The rationale for using community ownership to replace community participation. Up till now, the mainstream still predominantly use the concept of community participation that was introduced in 1970s. And it didn't become popular until the beginning of this century, and now it became the mainstream. everybody, every organization are using that, talking about that. But the challenge and the problem of that is when that concept become mainstream, people just follow that trend without sincerely practicing it, and the community participation leave too much room for interpretation and for diluting. And to the extent, as I observed, the vast majority of organization people who claim they practicing community participation were generally lip services or symbolic. And this is the rationale why we introduced the stronger term of community ownership that doesn't leave much room to dilute, whereas participation can be anywhere. And so that's the rationale. And I also began to see some of my colleagues recently begin to use that term, but community participation is still the mainstream concept. And
Okay, does anybody have anything more to say about community ownership and governance section? One of the things that I had, well, let me say at this point, so a document that we haven't seen the final version. Jenny will make some edits, but does anybody have any disagreement or concern that we haven't talked about a document to present to the full board? Seeing no concerns. One of the things that I wanted to carry the conversation into at this point is if we have a set of a set of overarching principles, I think it's useful to consider for the work of the governance board, where are we falling short on those principles. So I jotted out some as just as discussion starters to see if we have resonance with them when we where we're falling short on starting with maximizing health. The problem that some people, because of barriers, unnecessary obstacles to seeking care, which could be money, distance, intimidation, that we are aware that populations, they avoid seeking care, they avoid preventions and screenings. So I see that as one example of we are falling short on maximizing health. So that one of our operational goals would be to remove those obstacles that are discouraging people from, particularly from preventions and screenings that we know could help them. Does anybody have any addition to that kind of example of where we're falling short? I think we're falling short all over the place in behavioral health. But I don't know exactly how to describe that. I'll throw out just a few other ideas in fair distribution of medical resources. I see a key point where we're falling short is having different provider reimbursements rates depending on who the patient is.
Can we move the screen up so we can see? Are we now talking about number 2? Thanks. Or is this the section that you're talking about? Warren?
Yes.
Okay,
Thank
you.
Yes, I'm looking for where we're falling short. We didn't get any comment on maximizing health, but yeah, so we're looking at fair distribution. Yes, Amy.
Oh, sorry, I just wanted to make sure we were looking at the same thing.
But examples of falling short is, I call it the caste system, where if your or providers are paid on average, according to the task force actuarial report, $1.37 for private insurance, 81 cents for Medicare, and 69 cents for Medicaid. And I see that as being something that we need to change. And certainly we have the, oh, Michelle, please.
Sorry, my Zoom froze for a little bit, so I wasn't able to participate. I really appreciate this discussion, Warren, and I appreciate your comments on where we're falling short. I think it's really important that we also, to me, in the number one of above, to maximize health, I think that we, by necessity, really focus on the most acute crises in healthcare. But I think another way that we fail is that we don't have a good system for maximizing anyone's health. Really? I mean, that's not what we do. We deal with crises and we deal with them badly and we triage. But I think that it is important just to state that I think there is a lot of potential for universal healthcare to not only meet needs that have gone unmet, but to actually improve overall health because it could reduce cost, because it could increase meaningful access to preventative care. And I don't want to lose sight of that. Even though we have to tend to the emergencies right now, I think the long-term goal in my mind is to actually maximize everyone's health, and not just deal with broken arms and mental health crises and, those types of things. So I just wanted to mention that.
Okay, thank you, Michelle. Debbie.
I would agree. I think we currently have a very reactionary and fragmented system, and the emphasis really needs to be on thinking of things more holistically and less fragmented. Like for me, at least, mental health is a part of health. Like I know our systems are very separate in that way, and there are care considerations, but I like to remember that is certainly a part of an individual's overall health. And yeah, just moving towards more kind of prioritizing prevention, health, screenings, as opposed to constantly playing catch up to when things go awry. And as Michelle says, doing so poorly, not just because it's cost effective, but also it's the right thing to do.
Thank you. I'll just offer, well, I agree with you, Debbie, and with Michelle. I'm a little bit concerned about when we as, let's say, we as leaders decide that we're going to make people healthier. Then there has to be a little bit of definition from the community on what that means. And if someone is going to be happiest by eating comfort food, how far do we tell them that do those choices for them? I guess I'm expecting some community pushback. Amy.
I don't think I heard anyone say anything about individual, like, those kind of things, like what people are eating or whether or not they're smoking or drinking, but more about the system piece in terms of we currently are in a crisis care system is what I heard the last two comments were about. So the system piece as opposed to the individual is what I think we have more control over.
Okay, Michelle.
I think that that comment was in the document with some of the revised changes. That's where I saw that.
Oh,
That
okay, I missed that.
But I think that was basically my feedback, is that I think we've had a system that has both been a reactionary crisis care system and also has really put the entire burden of health on the individual in many ways, and it hasn't worked. I think we got to stop doing what doesn't work, from my personal view. And what we've ignored and what we do have, like you just pointed out, Amy, more control over is, what is our system of care? What is our system of delivery? What barriers can we acknowledge and work to eliminate? And that's something that from my perspective, we've never actually tried in a robust systemic way within healthcare. And I think that that could be a really productive shift in focus. And I think we've started in that direction with healthcare modernization in public health, but I think in the healthcare system overall, we have not seen that, because it's the industry can externalize basically the responsibility to individual patients and consumers while reaping profits from crisis care. And that's the system that I think we're trying to disrupt.
Okay, thank you, Michelle. Looking at things that we're doing wrong relative to financial hardship. There are, and I've time to time go back and look at the bankruptcy statistics. Bankruptcy has fallen quite a lot since the ACA, that requires or enables more people to get more insurance, but we're clearly still not there. So I think certainly anything that we can do to reduce cost sharing, including deductibles, will minimize effect, will minimize financial hardship. Any other comment about financial hardship and where we're falling short? Debbie.
Just speaking to our current system, I think just the runaway costs of healthcare that are excessive and seem to have no limits, which ultimately affects the individuals that are interacting with that system and seeking care.
Yes, Michelle.
I would agree with that comment. I think the challenge has been, which Oregon as a state has been wrestling with, what can we do about runaway healthcare costs? I don't know the simple answer to that, unfortunately. Maybe one of you does. But I think one thing we maybe could target is transparency in healthcare costs. I think one reason we see runaway healthcare costs is because the same procedure could cost 300% more in one place than another, and within the same state. And the lack of transparency really makes it harder to get a handle on costs. And I think more sunlight makes it easier to find some solutions, and also increases public pressure and regulatory pressure for price gouging. So I would suggest that as something that we could maybe target.
Excellent. Chenwei.
Yeah, I fully agree with what Michelle just mentioned, and Debbie. Perhaps one item we may consider to include in this third point, minimize financial hardship, is how the system we are planning should do its best to control the healthcare cost inflation, or minimize the inflation of the healthcare cost, that as a separate item, because that the inflation of healthcare costs will have a profound impact on every dimension of this minimizing financial hardship. And then the last one I already mentioned, we may want to include an item regarding the ability to pay principal in taxation.
Thank you. There was, I forget exactly who said what, but it reminded me that I'm not sure that we have in here somewhere is the effect of individual stress. And it had to do with the comment about transparency. And when you maybe need an ambulance, I mean, we've all heard of someone who needs an ambulance. No, please don't. I don't know what it will cost. You know, this could ruin me financially if, you know, I think we don't talk enough about the individual effects of complexity on stress of the not knowing what it will cost. And that actually is, I think, a major reason why people avoid care that they should otherwise that they would otherwise go get. Michelle.
I couldn't agree more, Warren. I really appreciate that comment. And we know that stress is a huge driver in chronic disease, in autoimmune, the rise in autoimmune rates of autoimmune diseases. And those can significantly impact quality of life over a lifetime. But I would also just point to the fact that, at least anecdotally, I think that there's a compelling case to be made that impacts individuals certainly, but also impacts larger institutions and communities. I was speaking with, by way of example, I was speaking with a 21-year-old yesterday who lives with and manages a chronic health condition, Crohn's disease. And they shared with me that they don't think they'll ever get married, not because they don't want to, but because their out-of-pocket costs even with insurance are so high that they believe that they will have so much medical debt that they don't want to leave a surviving spouse with medical debt if they were to pass. And so they are not going to get married. And just thinking, this is a 21-year-old looking at a lifetime of managing a chronic disease. So I think that the individual and the community both pay when we have this type of system.
Well, I hope we can find a place to talk a little bit about stress somewhere in here. We're running a little bit short, but if Jenny, if we can figure out a place to put that, and the task force heard tragic stories from people whose debt and not knowing what their future costs would be led to suicide. And I think I mean, that is a very obvious situation of stress killing, but stress kills in more subtle ways than suddenly. And stress is huge, I believe, and we should talk more about it. Let's take just a few minutes to talk about things where we're falling short in the ideas of community ownership and governance. Certainly, it's obvious, I think, to a lot of us that our current system is not economically sustainable. And that's actually what got me involved in universal health care in the first place, is you know, trying to the runaway costs and all of that. You know, I believe that in universal care there really are major efficiencies that reducing the cost solves a lot of problems, and getting it more in line with what it is in other countries. But where do other people think we might be falling short in community? Certainly, to Chun-Wei's point, I don't feel like I have any sense of ownership in the current system. It's all beyond my control. I get a call telling me that I need to find a new PCP because the last one quit, or I mean, it feels like being drugged backwards through a briar patch rather than having any control. Does anybody, Michelle, please.
That's a good description, Warren. I agree. I think a lot of people feel like healthcare, to the degree that we have it, happens to us, rather than it's something we have any ownership over. And I would just point to I think there's such a lack of, it's politically unsustainable, our current system, because we don't have, there's so much distrust because of that lack of transparency, because of the lack of accountability, because of not feeling ownership. And that distrust cost us in lives during the COVID pandemic. The fact that people didn't have trusting relationships with their providers and with healthcare as an institution meant that people weren't willing to take guidance that could have saved lives. And I think that that's something we're going to encounter in future crises if we can't repair some trust by increasing community ownership.
Excellent, Michelle. I think distrust is a very important item. Chun-Wei.
I have a suggestion about adding a bullet point under the community ownership. That is for the board to develop and perhaps institutionalize a mechanism for regular collection and obtaining community value and preferences throughout the process and continue on after the universal health plan is implemented. So we need to have some kind of institutionalized mechanism to obtain community voice, value, preferences, and that need to be an ongoing process throughout, not just before the implementation, but also after the implementation.
Thank you, Chun-Wei. Jenny, could you take us home? Finish up the meeting.
Thanks, Warren. Okay, it looks like I just want to clarify one thing before I wrap us up. On Dr. Cheese, on your final point, when you said collect community preferences on how healthcare is delivered.
Not just how healthcare delivered, as I mentioned earlier, the community ownership principle argue that for vital, important policy decisions, community should have the final say. And so this is referring to vital, important decisions, not every detail. That's not feasible. Just whenever, for example, what should be the equity principle? These are important principle guiding. So only those very important, but also the reason I suggest an institutionalized process of community voice expressing the values is so in the process of developing this plan, we need continuous to have community voice input heard. So this is a practice of community ownership. But after the universal health plan is implemented, we continue to need the community voice and values, because no matter what we end up implementing, they will not be static. They will continue to evolve. And how they evolve, we need the community, not just participation, their voice to influencing the decision and shaping this system. And that's why I suggested that the bullet point of developing or institutionalize the collection and obtaining community voice and values.
Thank you. Okay, now to bring us home. So Warren and I will work together. Katie's taking minutes. So once she's finalized those minutes, I'll go back and review those to sort of inform a little bit of the points, to sort of bulk up my notes. And Warren and I will work to put together a document that incorporates the principles themselves that I feel like everyone has agreed upon as overarching principles, and then some of the discussion questions and points that were made under each of those, to sort of fill out what the work group as a whole sort of discussed around this, and sort of where some of the recommendations were in terms of how we define each of the principles. Does that sound good?
Yeah, we won't have time to circulate that document that needs to go into the to the board packet, public packet tomorrow. So we'll do the best we can in the time we have, and because we're all members of the board, we will have an opportunity both to present this information and to discuss it in the context of the wider board, and it will be up to the wider board to approve. Do want to thank everybody from the public who is here, and Jenny, you can remind them about the opportunities.
Mhm. Yeah, of course. If anyone would like to submit comment, please do so. If you would like to do it in writing through the website provided on our webpage, which is, I believe, on the page with all of the board materials. And also, please feel free to attend the board meeting, which is going to be held on June 20th from 9 a.m. until noon. At the end of the board meeting, we do take public comment live during the board meeting. You can sign up ahead of time. You can show up during the meeting and give comment at that time if you would like. So please feel free to give any comment you have on the values and principles work that we've done in this work group. As I said, I think this will likely be the last time this group meets, unless during the board meeting next week, there is a request from the board for the work group to do any further work. So I want to thank all of the board members for your input and your work. Really like diving into these values and principles issues. I think that the work that's been done here really went to the spirit of what was hoped for when the board had the larger discussion. Warren?
Oh, thank you.
Great. Okay, thank you, everyone. Have a great afternoon, and we are adjourned.
Thanks.
Thank you, everyone.
Bye.
Thank you. Bye.
See you.